Hello, greetings from India. I am sorry for not being able to personally come and present this particular interesting presentation. I'll be talking about the Magnificent Plus and our experience, and also what does it mean to have a beyond enhanced monofocal IOL. Now, this is a lens which we have been using for nearly over 2.5 years, the predecessor of the Magnificent IOL, and this is a new model called the Magnificent Plus. We've done more than 7,000 lenses of the Magnificent IOL. Now, we will actually compare both of them and share our experience with them. There are no commercial declarations here for this particular product. Now, we are looking for the right solution for an iatrogenic presbyopia. The presbyopia corrected in a cataract patient or created in a cataract patient is actually done by the cataract surgeon. We've dealt with monovision, bifocal, trifocals, twinsetiles, pinels, and now the EDOF IOLs. So are the EDOF lenses or the enhanced monofocal lenses the missing link for correction of presbyopia? In this particular presentation, we will be actually discussing more our experience with the Magnificent Plus IOLs and also something about basics about spherical aberrations. There are four major categories of presbyopia correcting lenses: the multifocal IOLs, the enhanced monofocals, the extended depth of focus lenses, pinholes, and accommodative lenses. All work on major three basic principles: the diffraction, refraction, and pinhole. As we move forward, we will discuss more of that. And this slide is self-descriptive. Monofocal lenses will give you one single point of focus, whereas an EDOF lens will give you elongated point, a single point of focus with has an extended depth of focus. They are different than the multifocal lenses. Let's see how. In the multifocal lenses, you will have 2 points of focus. In a monofocal lens, you will have 1 point of discrete focus. Trifocal, you will have 3 points of focus with some areas of photic phenomenon or light loss areas. But let us define what is an EDOF lens. The ANSI defines the EDOF lens, a lens which gives you better than logMAR 2 in more than 50% of implanted eyes while giving a better or equivalent vision to a monofocal lens for distance best corrected. This is a very loose definition, but yes, it is a good definition to start with. Now, this is how an EDOF lens would work. Instead of having a single point of focus, you'll have an elongated point of focus in these particular lenses. So an object across this depth of focus will relatively appear clear. So you will have a light distribution curve, which is more a continuous all across the intermediate zone for these patients. In EDOF lens, there is a focus zone which stretches from one point to another without any actual secondary out of focus points, which are actually seen in diffractive lenses. Now, these lenses will not have out of focus points and they will avoid overlapping of images and thus eliminating the halo effect. Now, let us understand a spherical aberration first before we go to understanding an EDOF lens. In a positive spherical aberration, we all know the peripheral rays meet just before the paraxial rays. In a negative spherical aberration, the peripheral rays will focus beyond the paraxial or the central rays. So this is how it would look like. In a totally aspheric lens, you'll have a single point of focus, and in a positive spherical aberration lens, the paraxial rays will focus before the peripheral rays will focus before the paraxial rays. So this actually gives you a zone or a range of focus. You can play around with the negative spherical aberrations and the positive spherical aberrations to create a minor EDOF effect. Now this actually creates a tunnel, and this is the depth of the field of the IOL. Now this is what a depth of the field of focus point of an EDOF lens probably looks like. You have an elongated focal point and objects all across this focal point will be apparent to this patient. Now this will extend to the intermediate zone. As compared to a monofocal lens, as you bring the object closer to your eye, you will start seeing a defocus or a blur here, whereas in an EDOF lens, you can actually get the object here nearly 1.5 diopters near to the eye, and the patient still will be able to visualize the object. But both the depth of focus and quality of vision are antagonistic. You cannot indefinitely keep increasing the depth of focus because it will cause shadow effect, halo effect, and cause a blur zone. So there is a range with which you can play around. As this image says, as you keep increasing the dioptric part of the depth of focus, the halo effect or the shadow effect keeps increasing. Also, there is an alteration or distortion of the peripheral field of vision, and of course, loss of contrast. Why most of the people like us are moving away from multifocal lenses are these 9 C's which I describe here. And these are the reasons why we actually are slowly moving away from the diffractive lenses. Cystoid macular edema, corneal ocular surface diseases, centration of the IOL, pupil size dependency, more chair time to deal with these patients and all that. Now, most of the journals will give us the reason why there are so many reasons for explantations of multifocal lenses. The literature is full of them. Now, there are a lot of technologies of EDOF lenses which can be very, very confusing, but I will restrict this talk only to the Magnificent Plus. These are various lenses. I have used all of these lenses in my practice. My current favorite is one of these lenses is the Magnificent Plus lens. Now this is an eye-hands. An eye-hands gives you a near red of nearly 1 diopter in the center, slight myopia in the center. Now EDOF lens, as you see, has a smooth zone of defocus here, and there is also the MTF curve is very smooth with a larger area underneath it, which means it gives you a larger depth of focus without loss of much contrast. So the Magnificent Plus EDOF lens is identified by those two small little ports here. The lens has approximately 1.75 diopters depth added in the center over a 1.5 millimeter of the center part of the IOL. There's a smooth anterior surface blending which creates a depth of nearly 1.75 diopters. So these patients are doing very well without glasses for intermediate work. The lens is classically identified by these two little holes here. We have done nearly 7,000 magnificent IOLs over 2.5 years and exceptional results. And most of our patients, 68% of our patients, are happy to do day-to-day work without any glasses for near, intermediate, or distance. We use a blend zone of 0.5 diopters for these particular patients. But even the patients outside this particular subset are very happy. Now let us come to a small set of patients which we have used a Magnificent Plus lens. It's a recent thing. A follow-up is nearly approximately 3 months now. But here, amazingly, 76% of the patients in my practice and my study are doing very well without glasses for distance, intermediate, near. The trick we use is we use one eye emmetropia, and the second eye we go for the second myopia on the biometer as long as it is less than 0.4, minus 0.4, and these patients are doing exceptionally well. Preoperative chair time is most of the patients who are going in for EDOFs are the ones who are very allergic or very averse to experiencing dysphotopsias. Most of them are very okay to have a good intermediate vision and are not pushing in for very good near vision. And the concept of monovision, mild nano vision is explained to these patients, especially if the patient has larger pupils. So we go for a blend zone if the patient has a very large pupil. If the patient has a small pupil, we don't go in for the blend zone. Only minority of patients are opting in our practice for diffractive multifocal lenses. So what are the different layers which influence patient satisfactions? Of course, the cornea, the surface disorders, the aberrations, the accuracy of the biometry, very deep, very shallow anterior chamber, a very large or a very small pupil, IOL centration, surgeon-induced astigmatism, and the end refraction, and then of course the patient's expectations. A very small pupil, as I said, this is a brief summary of all the exclusion criteria, non-ideal candidates. Just like a diffractive lens, but these lenses, EDOF lenses, are far more forgiving than the diffractive lenses. The height of the patient becomes very important when you're dealing with EDOF lenses. A very tall patient will be very, very happy even with non-blind vision, and they'll be able to see N6 also for near without any near add glasses. So in our experience, more than 7,000 cases done, long follow-up over 2 years, very, very happy patients. The surgeons are happy, the patients are happy. We welcome more innovative IOL designs on this. And as regarding the Magnificent Plus, though it's a short-term follow-up, small number of patients, patients are far more happier than the Magnificent lens, and I think bilateral implants for these lenses do fantastically well, and these lenses do very well for me in my practice. Now here I'll demonstrate this new beautiful injector system for the Magnificent Plus. It comes with a dual method. You can use the push injector system and also the rotating screw type injector. There are two wings on the sides of the injector system. You pull out these two wings. Now these forms for your index and middle finger, and you can use the plunger to push it through single push technique, and there is also a rotating system in case you prefer the screw type technique of injecting. You push viscoelastic under the plastic flange in the cartridge tunnel, and then also put some viscoelastic in the thin part of the cartridge tunnel, close the butterfly wings, and now your lens is ready.